Good morning, everybody. It's 9:30, and I really like to welcome all of you to this EUDF Symposium. My name is Stefano Del Prato. I'm a diabetologist. I've been a diabetologist for the past 40 years and plus. It is my great pleasure, as I already said, to welcome all of you, and I'm very glad to see many of you here to attend this symposium, which is on artificial intelligence. Now, artificial intelligence is really becoming a part of our life, for good or bad. That will be something that we will be discussing. But within the EUDF, the European Diabetes Foundation, we have considered it's time to get the community to get together and to discuss what is AI and what AI could represent for the management of people with the diabetes. I think we are just at the beginning of a journey. It's going to be a very fascinating journey, maybe not that simple sometimes, but I was reading on the JAMA, on the series on AI in medicine. One thing that I really made part of my belief: AI should not be on physician or on people with diabetes, but should be with physician and with people with diabetes. And this is what we within the European Diabetes Foundation Forum are trying to do. If I can have my first slide, I probably need to go to the podium, otherwise, it's not going to work. So the symposium here, as you can see, is AI-driven clinical decision support system, potential concern, and what to expect. How can I get my next slide, please? And there is no mouse here. Where is it?
Ma hanno tolto il mouse.
Hanno tolto il mouse. Oh,
Ecco.
the mouse has gone away. Grazie. So this, what you can see here, is what we are trying to achieve. We have convened a working group to start, discussing about, the potential, the challenges, and the concern about AI, but with the objective to really make the communities already said to discuss about it. The overarching objective of the working group is to present an initial roadmap and recommendations and to explore whether there is a need and room for a consensus and guidance. We need to understand together, and AI doesn't mean only implementation, but also education of those people that are going to use it. For this reason, as I said, we have convened a group which is not necessarily a group of experts, but actually is a group of people representing different associations, different interests, different stakeholders in the field of the diabetes community to really get together and to discuss this topic. And what you are going to have today, it's an initial discussion. And we have three speakers that are going to discuss some of this topic. We will have first Dr. Lutz Heinemann, that is going to discuss about AI for diabetes management and the state of the art today. We will also hear, the voice of the representation of the people with the diabetes, and we'll have Mia Bajromagic discussing about the potential and concerns linked to the use of AI from the person with diabetes perspective, which is very important because this is our final goal. And finally, we will have Professor Taddei Battaglino to start delineating what could be the roadmap for implementing AI. Not a simple task, but I think it's a task that we need to go through. So this is, I said, is a sort of a kick-off time. This is the time when we start discussing on this. And we would really like to have your input at the discussion, because we want really to capture the feeling, to capture what is the current understanding from the community about the potential of the AI. As I said, this is just the start of a process. This process will lead also to a document that will be released by in a couple of months or so, definitely for the time of the ESD annual meeting. So if you are interested to follow up what is the development on the discussion about AI in the field of diabetes, please come and join us at the ESD in Madrid next September. And with that, and without any further ado, I'd really like to invite Professor Lutz Anran to come to the podium. I don't think that he requires much introduction, but he has a background of engineering, biology. He's the founder of Profil that has been instrumental to define and understand the PK/PD of many of the drugs that we are using nowadays, but also is a very much respected expert in the field of technology of diabetes. Lutz, it's up to you. Thank you.
So thank you very much, Stefano. Good morning, everybody. So I'm not definitely sure why I was selected to give you this little introductory talk here. And the next 2 hours I will talk and I'll show you 200 slides or something like this. So in order to give you an introduction into intelligence, and I somehow had to use my own intelligence to find a way to give you a hopefully interesting start here in 15 minutes. I hope that my time is not too short. So I'm supposed to show you here my conflict of interest. As you can see, I'm active in a number of different directions. So open API, open AI, will it take the world in storm here by storm? Will it alter diabetes care forever? To make a long story short, I believe yes. At the ESD last year, and you could see here a picture of the 3 speakers, Peter Schwartz, Tadej, and Moshe, and also a number of people in the audience. So in other words, like now, there is a strong interest, as you can see, in the topic. One of the issues I have with the topic is what we are talking about. Everybody has a different interpretation of AI. Everybody has an idea or whatever and so on. So I'm not sure that I'm able to help you in this respect very much, but I think one of the issues we have to come along in the future is common understanding of the topic. Some of the slides I will show you are from colleagues from France. So I think Stefano already mentioned some of the publications in JAMA and other high-ranked journals. Okay, AI is there. We have, especially in diabetes, we have a rising number of patients year by year. We have an increase in costs, and I come back to the topic of costs at the very end. At the same time, people are getting a little bit older that are taking care of patients with diabetes. So we have a decreased number of medical staff. So how to go ahead? How can technology, and this is one of the reasons I believe the ATTD is such a success, and I think we have to really congratulate Tadej and Moshe for organizing this conference here. At the same time, and I think this is also what you expect from somebody like myself, there is a gap, there are issues. And the question is, how can we on one hand have all these promises and have the other world, when I talk to colleagues about AI, they say, come on, it will not happen, will not have an impact on me in my daily life. And I will try to look a little bit into the gap and into the different questions there. So what is the current situation? What is the daily life in practices? If you think about your own situation, you come in and it's hectic, it's numerous people, you have to document everything, you have an economical pressure and so on. And what do you know about the given patient in front of you? I have your old data at your fingertips that you would like to have. So you have to make a decision now because the next X patients are waiting outside and so on. And at the same time, you have the idea, I have to focus on this tricky patient because he needs it and so on. So This is the situation. And when I talk to colleagues, many of them have some other, phrase it, let's say, skeptical or negative opinion on what's going on in the technological world. What is AI? Will it really be of help? There are a number of concerns the colleagues have, and I think we have to address them. We have to handle them adequately in order that they are willing to go with us into the future. So they see the chances. They know that it's as relevant for them. But the first point is we have to help them in daily life. We must reduce their workload. You see the exclamation point here. We have to help them, otherwise they will not accept it. We have to keep aspects like service quality, reliability, and so on in mind. So this is the last of these, busy slides. But I think diabetes is one of the areas where we have a good opportunity to use artificial intelligence, because diabetes management for me means data management. So we have numerous patients. We have many data, and day by day with CGM, AID systems, and so more of data mountains are showing up. So we have many data, but we need help, especially now coming back to the time aspect. How can clinical decision support systems and artificial intelligence help us to solve the issue here? I'm pretty sure that AI can help us because it can take care of many data. You have then the options to go into the depths of the knowledge that all the data present. Let me go a little bit a sidestep for a second. And as you can see, Moshe, I hope you can see it, presented in 2020 his ideas at the ATTD about the virtual diabetes clinic. After the ATTD, they published, or we published, the ideas about the virtual diabetes clinic. Is this a reality? What is a virtual diabetes clinic? Again, we have terms that are not well defined, that people have different opinions on, and so on. And we have terms, we have ideas of how to go ahead. And now the question is, what happens in reality? You find publications, and sorry if I can only show you the headlines of the publications, at least for most of them, but in 15 minutes I have no other chance. But my point is a little bit, yes, there are activities also driven by companies, also sometimes by big companies. We have also a European view on some of the ideas that are behind virtual diabetes clinics that need AI from my point of view. And there was a session some minutes ago in one of the other meeting rooms here where people talk from the Netherlands and other countries talked about their idea how to go ahead with the care of patients, what is the role of AI, and so on. So there are activities in this direction. Another topic, and we had another meeting some minutes ago about an aspect which we believe is quite critical. This is interoperability. When we talk about all the systems that should interact somehow, is this reality? No. If you talk to the people that work in practice, they say, oh, this device does not work with this one, who owns the data, and so on. There are many aspects of interoperability that also need standardization from my point of view. So what is the state of art of artificial intelligence and diabetes? The next slide probably gives you a little insight into it. This is a very simple thing you can do now these days by help of artificial intelligence. Go to PubMed, enter AI and diabetes, and this is the number of hits you get. And as you can see, how is the increase in the number of publications about the topic in the last years. And let me show you some publications. There was an excellent review in Diabetologia recently. If you are interested in details, I can really recommend this review. There are other articles here, as you can see, from a journal which is close to my heart, which looks more at a specific aspect, complication of diabetes. You can also find publications about AI and insulin titration. My impression is a little bit, if you look into the list of contents of good journals, if you want to get it accepted in diabetes or diabetes care, there must be machine learning or something like this in the title, otherwise you have no chance to get it accepted. Another topic where I see AI as a front runner is clinical diabetic retinopathy. There are a number of activities here and a lot of promises, and again, I'm not sure how the practical usage is. One example here, and I think it's also a little bit a kudos to Moshe Philip and his group and the other people from DreamMed. There's clearly the activity here of the AID system, which was or is somewhat supported by AI. And as you can see, this is of such a help that AI and diabetologists have a very similar outcome then. And I think this is somewhat we really need. We need good and convincing data. Why? Yeah. What are the obstacles to uptake, to a bigger uptake of AI in daily life? Again, this is a slide not by myself, but from a nice colleague in Germany who works with patients every day. And when I asked him, Friedhelm, what are your topics, thoughts? He gave me this list of different topics here. And as you can see, it's not possible for all the colleagues to attend the ATTD or other conferences. And they have not the personnel that has an understanding of the different approaches and so on. So there are a number of practical aspects that are of relevance. And costs. I think costs are clearly an issue because many of the colleagues that I have talked with said, oh, I invested hundreds of thousands of bucks or euros some years ago in an improvement in my IT system here. Never money comes back and so on. So I think we have to be very cautious in this aspect. We have to perform good studies in order to have the evidence also for the usage of AI from my point of view. So let me summarize here. I'm pretty sure AI will come. So a look in the future is somewhat easy this time. And I'm also sure that we only see a tip of the iceberg. So I'm pretty sure that in 10 years' time, if I would have to give, and I will not be here anymore, don't be afraid, if I would have to give such a talk again, we would smile about how naive we were some 10 years ago. So there are a number of, and I think this is also, and I liked how Stefano have started this, we have to bring our knowledge to the table. We have to be in this story and also to interact with all the other people here. We have to think about safety aspects. You cannot simply use this device without understanding really what's going on. So I think we are on the way. We have to shape it, and this is what we are doing also in this EUDF working group, and I think it's an important initiative, and that's it from my end for today. Thank you very much.
Thank you very much, Luz. I would maybe go to the end for a discussion or for your inputs, and in the meantime, I would really like to call to the podium Mia. Mia is a third-year medical degree, and she's here to bring the voice of the IDF, but also the voice of the people with the diabetes. She has been involved already in many activities in the field of diabetes, coordinating clinical projects. Mia, to you.
Thank you, Professor Stefano. It's a pleasure and an honor to be here today speaking at ATTD as a third-year medical student. I'm also the project coordinator at IDF Europe, and I focus on EU-funded projects, more of a clinical and patient-oriented side. So as IDF Europe and being part of the EUDF working group that focuses on artificial intelligence, I think it's a very important topic from a patient point of view. I also live with type 1 diabetes. I have been living with almost 10 years now, so I have a very unique perspective in both ends of the spectrum. We wanted to emphasize of why is it important to have the patient view and the patient perspective in the working group as part of the, I would say, a consortium member. So as a patient, we always focus on what this data will be used for and how it will be helpful. Of course, management and quality of life is the main focus, but patient privacy is also the main issue. So this is something that will be handled in the future. Like we said in the introduction of the working group, this is just the beginning. This is not an end of the story. It's a very very small beginning, and we are excited that we will be participating in the storyline. So artificial intelligence is coming if we want it or we don't want it. The main questions is how we focus on it and how we use it. As a patient, our main goal is to work with our healthcare team, to work alongside and to be part of our treatment plan, which IA-driven systems will hopefully give us the opportunity to achieve. Also, from a patient point of view, we want to be included. So we want to be part of the story, but not just the story being told on behalf of us. So the potential concerns of why we want to, just a second, okay. So like I said, data exchange and privacy is the main question, but also education and training. So will the confidence be present from our healthcare team? Also, will the confidence be present from a patient point of view? Will we be comfortable using artificial intelligence in treatment of our diabetes, type 1, type 2, and any other type of diabetes? As a patient, we hope not just to have better health outcomes, but what comes with long-term illness in general is quality of life. So for many years, we have had the similar medications to treat long-term illness, but what we usually see is the decline in from a X number of years in health outcomes from long-term patients. This doesn't necessarily come that the treatment is no longer working, but it comes from a mental and lifestyle burden of a long-term illness, which hopefully artificial intelligence will take an ease on and improve quality of life. The long-term illness cannot be healed. That's why it's called a long-term illness. But what can be done is the use of technology and new systems to actually better the quality of life and longer healthcare outcomes. So as a patient, we really want to emphasize that quality of life is as important as new medications and new treatment options. So these kind of go hand in hand. Also, there's a new wave, I would say, in the healthcare field of that we no longer just treat the physical signs, we also treat the mental aspect of any long-term illness, including diabetes. We also emphasize on community. That's why we are so driven at IDF Europe, the community and the strength that we give. Also, IDF Europe is consisted of healthcare professionals and patient representatives. So we kind of work alongside with the EUDF and other organizations and local and international ones to make the community as strong as possible. Also, we have learned that from patient experiences working alongside healthcare professionals in different projects and activities, that it's not just what our doctors or our nurses or our educators say, it's also the feedback that we get from the patients themselves. So it's a two-way street. The health outcome of any treatment plan in a long-term illness is a conjoined effort. So it's the effort that you get from your healthcare professional in getting you the treatment that you want, getting you the opportunity to adjust your treatment to the lifestyle you want, but also doing the work yourself. So taking care of yourself, making the lifestyle choices, using the medication as prescribed, and also being active in your treatment plan, asking the questions, asking, is there a better opportunity for myself? Is there a different approach? Even if you read something, commenting and with your healthcare team saying, oh, is this something that might be better for me? We are all human. Our healthcare professionals are all humans, and it's a conjoined effort. Also, from a patient point of view, we always ask a question about human factors. Will the potential new system be an overload to an existing healthcare professional overload clinic, or will this actually be an improvement in an overall guideline and delivery of medication and treatment outcomes? So yes, I think that from the long-term perspective, patient confidence in their healthcare team is as important as is the individual confidence of the healthcare professional themselves. And this will all come in the near future because we all learn from each other. And this is why we said this is the only beginning of the working group. It's a foundation. It's not a solution. It's a call that we invite you to contribute, and that we want to have a conjoined effort, and we want to share the knowledge and the findings. So yeah, we are very excited as IDF Europe to be representing the patient voice and to be giving the voice of the patients to actually be part of a not the treatment not being made for the patient, but actually the patients being made together with the treatment. So thank you for listening.
Thank you very much, Mia. Thanks a lot for the voice of the IDF and the expectation of the people with diabetes. Now, I do not need to introduce you the next speaker because it really is the driving force behind ATTD, but also the driving force behind the new concept in the treatment and monitoring of diabetes. Professor Taddei Battaglino will, as I already mentioned, will now try to take us through what could be the initial journey on a roadmap and guideline and consensus on AI and diabetes. Taddei, thank you.
Thank you very much, Stefano. Thank you very much for being with us. If we were happy with this small place that we had at the EISD and it was full, I'm really thrilled that people have to stand behind to listen to this session, because we do believe it's of extreme importance, although many of us do not understand it well. And this is an acknowledgement. This is probably my most important disclosure, more than this one's. What I would like to give you a little bit of examples of success, some of them brand new, so that we at least can believe that this is the right way to go in diabetes. I would like to just touch challenges, not too much, and then the roadmap that I'm supposed to discuss. This is, I think, it's an interesting paper. It's an interesting paper, perhaps not the best data set was used, but it is very possible to identify people at risk for type 2 from a general population. This is 60,000 individuals from the normal fasting glucose. I'm well known to say that glucose is dangerous. It's dangerous also within the normal range. And the UK Biobank study gave the best evidence to this. But not only the real data, the biobank, but also this actually machine learning exercise on the 68,000 individuals without diabetes, with a fasting blood glucose. Please note the risk that fasting blood glucose within the normal range, if you use machine learning, pose for development of type 2 diabetes. This is cardiovascular risk prediction, another beautiful example how you can, from very simple existing data, predict cardiovascular risk. And they tested this hypothesis on known data with CANA. As you know, CANA is protective. And they get exactly, please note, exactly the same curve with the simulation of the input data as with the real outcome from the study. So if you saw previously, when you compare artificial intelligence to the work of specialists in diabetes, this is very similar. They basically tested, compared artificial intelligence outcome with the real outcome from the study. And please note, they are basically identical. I'm using this picture just to tell you that there are different levels of artificial intelligence. Those that we all know, which is algorithms, the ones that are used in, let's say, an artificial pancreas at the moment. And then you go deeper and deeper. So you go machine learning, which perhaps we still understand, and you come to the neural networks that very few people in this world, I guess, really understand, and I'm certainly not one of them. If you listen to the lecture of Professor Boris Kovachev, he's using it already in a artificial insulin delivery system, and he even got, for the first version, the FDA approval. So it is getting very serious. It's here to stay, and that's why I think we need to understand it better, and also inside the European Union and our region, implement some guidance on how to do it. This is the best example. As you know, retinal exam, at least retinal screening, is now completely artificial intelligence driven. In my center, every person with diabetes gets to a camera. Also the OTC, so the angiography using erythrocytes, so there is no additional burden. And this goes directly to Finland, when the central server is, and I get back the risk score within 3 minutes on my screen. So it's amazing. Just imagine, before I had to, type a referral to an ophthalmologist, and she or he would look into it, and I get, I don't know when, the report back. This is now 3 minutes, and it's highly validated. As you know, it's FDA approved. And basically, during the discussion with this person, I already have back the risk score from the retinal exam and the retinal angiography performed with this electronic method. How is this possible? Well, exactly the same way. They used machine learning. They tested then with rock curves which model is the best, and they applied the model to the picture. It's a standard approach that I think most of us can still understand. However, it's a very, very expanding thing. So I was not able. This is an interesting Journal of Vascular Surgery, that my library doesn't have. So excuse me just for the simple picture. It was published a week ago, and what they did is they used Doppler, echo sound, ultrasound. They evaluated the plaques, and they applied machine learning and deep neuronal networks. Please note, deep neural networks for the analysis. They were able to predict, just from this analysis with artificial intelligence, the death with a hazard ratio of 3.5, 3.6 almost. MACE, MACE is the composite endpoint for cardiovascular, with a ratio of 2.6, and events in the lower limb with a hazard ratio of 13, which is an enormous hazard ratio, so an increase of risk based on the deep neuronal network analysis from the ultrasound of the vessel 13 times increased. But then another probably very, very important new thing is And I'm very privileged, I feel very privileged that the senior author of this paper, Professor Gunfor Sander, is sitting in the room with us, is assisting with artificial intelligence the identification of people in stage 2 of pre-type 1 diabetes who will progress and how we can identify these people. Again, the same model, so data examples, or then what I think Boris Lovely says, data farming, which is always the first step, and then output examples. And here we can see basically what we can achieve is, if you want me to summarize it, we can individually predict in a better way. We know as a group 70% will, from the stage 2 within 5 years will develop stage 3, so the beginning of type 1 diabetes. But who among these 10,000 people is the right person to address? And this is exactly where artificial intelligence can help us, number one. And number two, since we know who is at a higher risk inside this population, we can personalize the management. So perhaps somebody needs a CGM every 3 months, or the other perhaps just every year. So a very important help that can be derived from the artificial intelligence analysis in the screening and follow-up of those that were identified at risk for type 1 diabetes. Exactly the same thing for type 2 diabetes. This is a FASA adult cohort study, also published a couple of weeks ago. Exactly, please note that the same, so 10,000 people for data farming. Again, the first cycle with data farming, with the learning process, machine learning if you want, and then different algorithms applied for the analysis, for the output of this data. The data are then tested with the ROC approach, and then, of course, applied for the outcomes. And this is the outcome. Very easy. A person without diabetes, and males and females, importantly, have different risks. Of course, sugar product consumption, number one. Glucose is dangerous. And you go down and down, and then to people with diabetes, so a male person with diabetes. Look at, please, again, the first is sugar products consumption, both in males and females, just as an example. So the success is there. Management of diabetes will include artificial intelligence, we like it or not, and I believe for the good. We just have to learn and try to accept it as soon as possible. There is potential in improving care, increased personalization, which I believe is super important in diabetes. Perhaps, of course, I hope success. And it will shorten and standardize decision pathways, which particularly with this overburden of the medical system is important. Finally, what is new, we can also support screening, identifying people at an increased risk. Do we see challenges? We do. Let me give you this example. It's actually the GoFood application. I think a very sophisticated application that worked well in testing environment, but please note, user satisfaction was extremely low. And this is the message that Mia gave us. Unless you include people in this development of artificial intelligence support or apps, or initially, from the very beginning, into what is called a living lab, we are unlikely to be successful. Because if the end user, if the person with diabetes doesn't like it, I mean, despite the fact it may be the best technology behind and the best whatever, we will fail. So inclusiveness of people with diabetes from the beginning of development of these tools is crucial. And if you look at this meta-analysis, this is also published a week ago, of different applications for type 2 diabetes, please look, I mean, despite the Kamlesh's study is a little bit less convincing, the last one, but all others are quite successful, so it can work, it can help. The conclusion of this meta-analysis is that the co-design with the end user is paramount, actually, again, to be successful. So how, with knowing all this that we now together went through very quickly, how should the development of such a roadmap, of a guideline look? So we had this initial idea, and the work group started to work really in September, so a couple of months ago, last year. This is the composition of the group. So as you can see, several organizations reunited. We have, EPIA, which is now different. We have MedTech. We have EISD, EFSSD. We have IDF. We have FINT, which is the Educators and Nurses Association. Obviously, we have the EUDF with BART, that is basically the motor and the help and the person that coordinates all these efforts. This was the initial literature review, quite extensive, that we did. So as you can see, as Lutz showed you, now it's several thousand papers a year. We use the standard approach, the standard approach of this analysis. And first of all, we identified these levels of artificial intelligence use that I already described to you, and also how this can communicate with other systems in existence, particularly with different healthcare systems, because embedment into the electronic medical records for any system will be crucial. Mia described to you this picture. I'm just repeating that any artificial intelligence data use, the person that is actually, the reason why we do all this should be included from the very beginning. We identified targets for initial Delphi survey that you can see here, and the right pathway was actually the pathway that's accurate and efficient, it's safe, it's accepted by the user in long term, has a continuous deep learning and optimization, which is typical for the neural networks. They learn continuously and improve. And please, bear with me, we have some results on this pathway. So the survey teams at selection done, selected, the first Delphi survey was executed, we got the replies back from all these people that participated, we collected the data and started interpretation, and the round 2 is en route. So what is needed now is to put this together and do a consensus statement, hopefully by the fall of this year. After we do this, as you can see, here are several steps. So the first 3 are done. Here are several steps that are in front of us. Some are quite difficult for physicians and people with diabetes, so we will ask help of engineers that understand this much better. But hopefully, in the end, we can get with a comprehensive but also understandable initial guidance in this process. Allow me a couple of conclusions to propose to you. So we believe not only artificial intelligence will come, we believe it's helpful. There are barriers, so we need solutions to these barriers early on, the sooner the better. Number one, it's data standardization and coding, super important if we want to exchange this data inside the European Union and beyond. It should be on open, standardized platforms, so not a company-owned platform, but an open platform that everybody can use and get benefit from. We should optimize algorithms or machine learning or hopefully neural networks, because this is really where all is going. We need to involve all stakeholders, also payers, particularly regulatory bodies. In Europe, we are a little bit behind the United States in this regard, so we have to catch up and really drive this catch up with the regulatory bodies in the European Union. And as I said initially, we need involvement of people with diabetes in a living lab model, which means from the very beginning and throughout the pathway. And we are very grateful to Mia that she is with us and is helping us with her expertise from this site. So EUDF roadmap and guideline plan is rolled out, is ongoing, and I do hope, we'll be able to present it to you very, very soon. Standards for development that would come from the regulatory part is the final goal that we want to see inside the European Union. With this, I thank you very much for your attention. This is my team. They have to work while I speak.
Thank you, Tadej. Can I invite you, Lutz, Mia, please join me here so we can have some discussion. We have some questions from people following us on online, but you know the symposium, it's open to comment, discussion, suggestion from you. Is there any comment?
I have a question.
Yes, please.
Hi, I am Riccardo Bellassi, University of Pavia. I work in AI in medicine since ever, so that's a natural question. Thank you for the presentation and for raising a lot of very important issues related to application of AI in diabetes care. As you mentioned, AI is a set of diverse technologies, and I would say that while in the area of predictive modeling, there is a sort of way now that is not call it standardized, but is at least published to evaluate the models and to assess them, and you correctly mentioned this. There is this other area that is related to generative AI that has been mentioned at the very beginning of the presentation, that really opens a number of issues. Generative AI, you know, is like ChatGPT and family. That means that we are able to have interaction with the system that is able to generate outputs in a sort of natural way. So the question is, if your study group is explicitly studying these, the potentials and dangers of the use of this technology for the management of diabetes, that goes from assisting the clinician to interacting in a natural way with patients and caregivers.
Lutz, do you have any comment on that?
To be honest, not. I think Riccardo's statements are clearly straightforward and perfect, so I think that's clearly something we need cooperation with people like Riccardo, I would say. As a working group here, clearly you are invited, and this is what Stefano also indicated. We are desperately need people like you.
But Riccardo, first of all, good to see you. But again, as I said, you know, in the introduction of this symposium, this is not a body of experts on AI. This is a body of people, if you allow me, with a passion for diabetes, that are trying to start understanding what is the potential of AI. And definitely, I mean, you are the expert, and you are the one that also needed to warn us about, you know, the pros, the cons, the potential danger, and the potential advantages. So we were seeking for inputs for people that do know what AI is, what are the technicalities, and what is the implication of that. But that's exactly what we want to do. We want to start this discussion. So thank you very much for bringing this up. Today, do you have anything you'd like to add on this? Please.
Hi, I'm Dr. Amit Dev from India. I've got a couple of questions. One is, of course, as we understand that, you know, in today's era, doctors should be bilingual. We must understand the medical terminologies as much as we should understand the technical terminologies. So any plans from the working group on promoting AI literacy amongst the clinicians? That's one question. And my second question is in terms of the use of generative AI and large language models, or even the open source small or medium language models as a part of the clinical decision support system. How do you see the GDPR, the EU Data Protection Act, shaping this up, you know, in your domain? These are my two questions.
Today, GDPR.
Thank you very much. You know, it's interesting. So first, thank you. I think Lutz, or I think Stefano this morning said it, that when we started medical school, we had stethoscope, you know, and this was very sophisticated, wasn't it? And now, obviously, I think should be part of the medical education. I very much agree with it. There is no other way. There is no other way, right? GDPR, I may surprise you, but I don't hate it so much. I think it's a good law. I really think it's a good law. Please compare the European Union situation to the United States. So it does protect people. So I'm very happy to respect it. There are very clear paragraphs in it that also enable data usage for the benefit of people. So I am not afraid of GDPR, but we cannot simply use ChatGPT, right? So we must have, medically approved, designed, and, examined applications. And then, this, of course, will be compliant by the GDPR also.
Thank you all for such a wonderful presentation. And Prof, today I feel like I've been following your presentations around the whole conference, so thank you so much. As a humble AI enthusiast and quite a big fan, my question, and please challenge this premise, is that we know in medtech and we know that in pharmaceutical research that 70 to 80% of research participants are white or of European descent. And when we are looking at guidelines for academia and when we're looking at guidelines for industry, and we understand the research that we have into unconscious bias, are we at the possibility of sort of coding into deep learning and into AI our unconscious bias if we don't put a guideline or a stipulation into including all members of society into this? And in the circles that I run in, we do consider that as a risk for AI if we're not all included at starting how we want to finish, as it were.
I've read here another question, so I'm not able to listen.
Yeah, do you have any comment on that?
If I understood correctly, you suggest to include the entire society?
No, more of, so if we still work on, if we don't as a guideline in terms of standards for research, and if we still move forward with 80% of white participants, we could be programming AI to exclude the other 20% or the 80% of the world population as a possibility, in terms of having something that serves all of us.
No, I mean, obviously we need to include everybody, so that wasn't I didn't think that was an issue. And, interestingly enough, I think the white population here is behind. Look at India. India is super advanced in computers and, programming. Most of the companies work there.
But the actual studies...
And they are a
that
billion and something, right? So it may be the opposite in this particular case, that white will be a minority, which is fine.
Yeah, but it's just for research to reflect that, is my only comment.
No, but if I comment, I think that your point you raised, may be of interest because, of course, technology, AI can be expensive, and from that point of view, it may be implemented first in areas that are wealthier as compared to other, and because of that, it may generate, an even larger gap in terms of. This is an ethical issue that we all need to keep in mind very clearly. And that's something that we need to, it cannot be a solution for people living in Europe or in the United States. I mean, we really have to do this for people with diabetes. That will also require not only a lot of effort in terms of gaining the technical information that we need, but also to make sure that this translates down to as many as possible people with the diabetes. This is the final goal for sure. Not simple. We have to admit it. It's not simple, but it requires the participation of everybody.
So before continuing with the next question here, there are a number of questions that we received via the internet. There's one question here, it's about the role of the working group to mandate manufacturers and HR companies to standardize data interoperability. Somewhat a tricky area, I would say. Clearly, such a working group cannot mandate somebody else. However, at the same time, I think also that we as the experts in a certain area should not underestimate our impact, our opportunities that we have to influence manufacturer and so on. So if we have some ideas about standardization, and we discussed earlier today about interoperability, there is a need for standardized protocols and so on. So we can have an impact, and I think such a working group is a good opportunity to impact the reality of the other people, of the manufacturer. In a sense, they are looking or waiting to have a guidance by the expert on how to go ahead.
Yeah, if I can also add, Lutz, within the EUDF, okay, we have members, but we have a sponsor that are representative of the industry. and also from the technology related to diabetes. So there is an opportunity there to have at least an open discussion, and out of this discussion we can also try to generalize or to have a more standardized procedure, and that's one of the good things about the European Diabetes Forum, I believe.
And also, I speak now in the place of Mia and myself at IDF Europe. So we actually address the European Parliament with this, and will continue with this action and the document, so that the newly elected European representation this June will actually start working on this also, hopefully, finally with legislation, with directives that would mandate as suggested. So it's not a promise, but the promise is inside the IDF Europe, we will work on it.
Today, since you are mentioning it, allow me to remind everybody here that the European Diabetes Forum and all the association within the European Diabetes Forum has come up with a pledge for the upcoming election of the new parliament. So I really like to invite all of you who would like to support that pledge, and that in that pledge also there is also the technology, to go to the EUDF.org and sign the pledge to support this request for the future parliament. Please, next question.
A brief comment to Dr. Patrino. I totally agree with your statement of the importance of open platform for everyone, because AI, I'm working on food and diet, and it's really conflict with the domain issues, because AI work just within the domain it conducted the machine learning, and we really need the broad open source data set to let the machine learning. So please make the worldwide open source data sets for machine learning. Thank you.
Thank you.
Thank you.
Just a statement following on from the question the lady raised earlier about unconscious bias. We've learned from corporate AI systems that simply the name of a person can bias a decision system to not give a mortgage loan or a credit card because it infers gender. Often AI systems are trained off historical data. We know there's evidence that women are treated differently to men in the clinical environment. So I would urge that any consensus statement that is made addresses that we make sure that we do not inherently bias our decision systems to continue the tragedies of the past.
But actually, if I can comment on that today, I think AI or the integrated analysis of data is the solution for that, because what we are striving for is individualized treatment, personalized treatment, and that will incorporating gender, environment you live in, the biological background, blueprints, and so on and so forth. So ideally, that will be the way out of this kind of separation that we are still living in.
It depends on how the decision tree is being trained. So if the decision tree is being trained on poor data, it will make poor decisions. For example, yesterday we learned that there's an inherent difference in insulin resistance between males and females. That is good information to know. If that's not used appropriately in the decision tree, it's going to give poor outcomes.
Thank you very much. So as you notice, the prediction algorithm for type 2 is already gender specific. And probably 2 months ago, in a funny journal, I think, a beautiful study was published on 12,000 young healthy individuals, the superhuman, clearly showed that the female normal glucose is significantly lower than males. And just think about, we have a higher mortality in type 1 diabetes in females, and we use the same targets for glucose. So, I very much acknowledge what you said, and I think it's a timely remark because it's an International Women's Day today, so my sincere congratulations to all of you.
And actually, since we are coming to the end of this symposium, I'd really like to conclude from one question, which is actually a comment to what we've been already discussed right now, but just again to underline what day is today. And the question was, the AI models are as good as the data entered, and thus, on International Women's Day today, one has to ask how we can avoid increased discrimination of women and their different outcomes with AI. And with that, I really ask to Mia to give the final word. as a very active woman in the field. Please, your last word.
Thank you. So I encourage every woman to fight for what they think they need and to use their voice. And I think the industry is changing in a very positive way. I don't think that it's as noticeable as it was in the past, but we always have room to improve. And we always have to, so the gender and our achievements are what defines us and not our looks, backgrounds, and genders. So that will be my message.
And with that, I would really like to thank our speaker, and particularly like to thank all of you. This has been a very crowded room, and I think we are right on the spot to discuss this. Thank you very much.
Thank you.